My name is Zafar Khalilullah. I'm one of the recently graduated CVR fellows and currently in Winchester, Virginia. And so today I'll be talking about the long-term results of endovenous therapies for superficial reflux. And before I start the discussion, I just want to share my experience that throughout the year, a lot of patients, when we recommend any sort of treatments in the venous therapy, the questions I usually get is this a one and done thing? Do I have to get this treatment again? Why does this keep happening to me? Why I'm going to keep getting different treatments on my legs? And so they want to know the long-term effect of this treatment. So I think I had a good opportunity to look up some data and try to see the evidence and correctly answer the patient's questions. So I think this is kind of important for current fellows as well, and to see how we can, what kind of data we have to really try to educate our patients about the long-term results of the treatments that we offer. All right, let's see. Just want to start with the brief case of Miss O, and who's a 59-year-old female, was referred to our clinic by wound center for evaluation of the chronic leg wounds and recurrent varicose veins. And she reports a long history of bilateral leg ulcers for over 20 years, and she had underwent multiple saphenous vein ablations in two different facilities. Unfortunately, her wounds persist for many years and now still managed by a wound center. She's complaining of severe pain and heaviness and edema. She never had a DVT or PE. She's on warfarin for a long time for tricuspid valve disease since 1995. And she reportedly said the last GSV thermal ablation was over 4 years ago. And again, as we know that this is a progressive with the ulcers, that she has complications. She had multiple antibiotics treatments. She follows home health nurse, and she's been unfortunately going through a lot with the ulcers. And the last time she saw vascular surgery, she recommended no intervention. And this is the exam findings on the imaging you can see in our clinic a couple months ago. And you can see this is a advanced CVI with bilateral leg ulcers, C6 disease. And she also have bilateral varicosities, which you can see more prominent on the left side. And the both leg wounds you can see on all the imaging here. And this is her ultrasound findings. And you can see not only she end up having superficial system the reflux, but she also have a deep system reflux, especially more on the right side. And our vascular tech did a great job of pointing out all the pathologic perforators you can see and a lot of tributaries. And unfortunately, why she was not recommended a reintervention for a previous visit, which I have no idea. And again, this is the treatment plan we created. We get the chance to get approved majority of our treatment. And the reason why I'm presenting this case before talking is before our discussion, you can see we're doing the radiofrequency ablation, we're doing phlebectomy, we are doing ultrasound guided film, and we also try to close perforated with the RFS. And alternatively, you can also go with the laser and try to close those perforators. So she has had a recurrent disease, which is advanced, and she had multiple thermal ablations in the past. And now she would ask us why I'm getting all this, and is it really ever going to get better? And I know she was also referred to CVM. She has a lot going on, but just to when you get those patients, try to discuss the data that we have and how we really accurately can answer, like, okay, what is the long-term effect of each treatment that we're offering, and to set the appropriate expectations, which is important. And again, just a quick outline what we were talking about briefly, what's CVI, what's the quick background, and then I'll talk about a lot of data about radiofrequency ablation, what are the long-term studies show, and for the laser as well, and then what kind of clinical outcomes compared to thermal when it comes to ultrasound guided sclerotherapy, and then lastly, I'll talk about cyanoacrylate venous seal data, and then what is REVAS, which is recurrent varicosity after surgery. So background, as we already know, it's a common over 25 million adults get affected in US. And like our patients, 6 to 7 million have advanced disease, more common in women and men. And some global studies have shown the prevalence could be up to 80%. And we already know about the major risk factors, the age, female, and multiple gestation, and occupation and DVT, and obesity is a big one. And the new risk factors that I found interesting was the leg bioimpedance and increased height. The leg bioimpedance is the tissues resistant to current, or how the body's tissue measurement to the how they flow the current or resist. So in this graph, you can see all the risk factors and what's the probability of the varicose vein. And the last bottom, you can see the lower the leg bioimpedance, the higher probability of varicose veins, which really means that the body have a lot of fluid to blood ratio, and this is resist to the current. And management, which we already know, but the mostly, which I will talk about what kind of data we have, is endovenous ablations when we decide the patient's operative candidate, and then what data we have on thermal ablations and what's non-thermal, and then why high ligation and stripping became kind of obsolete. And this is just to summarize what we just talked about. And again, over the recent years, the goal of a treatment is not just purely technical success. What matters to us as a clinician and to the patient is what kind of symptoms improvement we get for the patient, what's function and quality of life and speed of recovery. This becomes more focus on our goals of treatment. We just don't look at the ultrasound and say, oh, it's closed, but then to see what kind of outcome impact we have on patients' symptoms, quality of life, and speed of recovery. And we do have, over the many years, the studies, we have created sleep classification, VCSS, and then quality of life questionnaires to really better assess our treatment outcomes. And again, this table I found, which is kind of summarize all the intervention for chronic venous insufficiency management. And the ones that we're really focusing on this topic is endovenous ablations and what are the long-term data. And again, I'll start with the RFA. And you can see RFA was initially was introduced in Europe in 1998, and a year later was approved by FDA in the US. And currently, American Venous Forum recommends has a grade 1 recommendation with moderate quality of evidence for treating symptomatic great saphenous vein reflux. And again, what kind of evidence we have, and compared to which the laser, which I'll talk about in a few slides, but over 17 randomized controlled trials have been done so far to really look at the mid to long-term follow-ups for RFA, and then 9 trials actually compared RFA to open surgery, and 8 of them compared to laser. We have recovery study, we have a closure study, which I'll talk about, and then multiple European multi-center 5-year studies have shown the evidence about RFA outcome. And then the lastly, the LARA study, which in our one of the meta-analysis, which we'll talk about that too. So and again, these many mid to long-term outcomes. You can see the first one, that's the Evolve study, the follow-up for 2 years, and there's many lists, but I'll talk about, and for the sake of time, we'll talk about the ones that I think is important. And so this one, done in France, and one of the early was studies published in the Journal of Vascular Surgery in 2005. This talks about long-term outcome in the venous RFA treating saphenous reflux. And this is a multi-center prospective cohort, observation cohort study. They looked at 34 centers worldwide and 12 of them with 5-year follow-up data. And in this study, over 1,000 patients and over 1,200 limbs were studied, and majority of them, 78% female. And then all of them got radiofrequency ablation, and then almost 50% of them had adjunctive phlebectomy, and around 10% had ultrasound guided sclerotherapy. So the goal was to follow up in 1 week, 6 months, 1 year, and annually for 5 years. And on primary outcome, they really want to look at what were the vein occlusions and reflux-free rates, and how clinically patients improved. They looked at the SEEP and VCSS, and also they try to identify if any risk factors that affecting the treatment outcome, like age, BMI, and pullback speed, or the vein diameter. So this is a table from the study. You can see shows a vein occlusion and hemodynamic outcomes from 1 week all the way to 5 years, and 1,000 patients, 1,200 limbs, and closure rate at 5 years was 87.2%, and reflux-free rate at 5 years was 83.8%. And then even though anatomic rate at 5 years, I think it was like less than 2%, which was 885 limbs over 1,200 limbs. And not only on like a ultrasound results, but they also look at the symptomatic improvement. If you can see in this graph, the pre-op initially, all the patients before intervention, like almost 90% had pain, and majority of the patient had a fatigue and edema. And pain reduction from a baseline from 85 reduced to 8.5 in 5 years. And you do see significant in the beginning, but then it stays throughout annually up to 5 years, and edema reduction. And the ones that had anatomical failure, which we talked about, like around 2%, 80% of those patients actually, even though they had some sort of reflux, but they were asymptomatic. And then lastly, they looked at the risk factors. Is this any risk factors also affect our treatment outcome? And at the past, RF was more like a pullback speed, which we don't, it's more standard different now. And they looked at pullback speed actually had a significant risk factor of the treatment outcome. And BMI was another risk factor that caused increased failures for odds ratio. And then the other variables like age, vein diameter that we think they were not significant affect the outcome. And this is the Evolve study, this is Evolve 1, and this is the 2 year follow-up. And this is the randomized control trial comparing RFA with the conventional surgery. And this is prospective randomized control trial. And this, they looked at 85 patients, and from evenly distributed to RFA group and then the stripping and ligation group. And they wanted to look at the follow-up was to look at ultrasound findings and then symptomatic SEEP and VCSS scores, and then civic 2 questionnaire. So the endpoint was really to see how the ultrasound, are we doing technical success, and what are the difference between those two groups, the GSV closure, and they're interesting to look at the recurrence and revascularization, and then VCSS progression quality of life score, which I'll talk about shortly. And this is just a study designed shown in imaging, pretty evenly distributed in the beginning, but unfortunately in 1 year and 2 years, the follow-up reduced from 44 to 36 limbs in RFA group. Similarly, some lost follow-up in 2 years in surgery group as well. And this is, I'm just going to talk about just results for the sake of time. You can see on the VCSS score initially, when it compares to surgery, RFA was significantly higher in the beginning, but then when it comes to 1 to 2 year outcome, they both had significant improvement on VCSS score, and as well as on quality of life score as well. And there's a big difference initial right after 3 days. You can see the RFA group had better outcome, but then over the years, over 1 or 2 years, they kind of similar. So there was some improvement. And this looked at the cumulative prevalence of varicosity, and they wanted to look at the rates of recurrence in each group. And when they combined 1 to 2 year follow-up, RFA had 14.3% R versus 20.9% on the stripping and ligation group. And lastly, one of the other randomized control trials that I wanted to talk about, but this was 5 year results of prospective European multicenter cohort study of the RFA of segmental thermal ablation for GSV, and this was done in France. This was just a prospective multicenter cohort study in Europe. They looked at 225 GSVs for radiofrequency ablations. And again, they assessed VCSS and what's the ultrasound findings of the GSV in 1 year, 3 years, and the 5 years. So this was one of the long, and I'll just talk about the results. And what they found was from all those 225, 91.9% had GSV occlusion at 5 years, and the reflux-free rate was pretty good at 94.9%. And again, there's some recanalization that looked at. The most interesting was 10 cases reflux located at the saphenofemoral junction, which I will talk about in a few slides, the why it's important of the idea of pelvic and peripheral reflux, what is the source of reflux when it comes to recanalization. And then this graph also shows that some improvement on VCSS score from the baseline. It was a median around 4, but then dropped to 1.3 at 5 years. So patient uh, significant improvement on VCSS. And I think I would encourage all the fellows to look up this. I think this is on the CME Drive, and this is one of the great uh, publications that overall is over 5 year long-term data. They looked at systemic meta-analysis, all randomized controlled trials that's done um, comparing endovenous laser, RFA to surgery, and even ultrasound guidance from sclera to the traditional surgery or lasers to really talk about what kind of outcome we have in 5 years. The focus was the primary outcome was to look at recurrence, reintervention, neovascularization, recanalization, quality of life, which there's a lot of graphs which I will share and try to make it simple. And again, before I talk about the study findings, just wanted to know what is the REVAS. REVAS is the recurrent varicosity after surgery, and etiology of recurrence veins is multifactorial. It involves residual, recurrent, new disease process, as well as neovascularization. It's very important to understand the distribution of reflux. As we know, a lot of pelvic reflux, like saphenofemoral junction and perforated veins, are actually the most common source of recurrence. And when it comes to residual disease, is this a tactical error? When it comes to technical, is this a pullback speed is low, we're not giving enough joule, or if this is a different physician techniques that they use. But tactical errors is to really jump into treating TRIS before that, the truncal endodermal ablation. So it's more our choose of treatment is an error. And then the new disease and also recurrent disease, and then the last new vascularization. Though all those five components, the really factor of how patients having recurrent varicose disease. And again, the last is just understanding the gender, family history, and other post-thrombotic changes. Those things are also understanding those can contribute to patients having recurrent varicose veins. And when it comes to recurrent disease, just to know if it's the same side, a different side. If it's the same side, is this really happening with the residual disease, or is this new vascularization? Especially, we don't see new vascularization much with our endovenous ablation. It used to be more common with the surgery and ligation. But overall, knowing the errors and how we can at least prevent or unable to prevent. So this going back to that meta-analysis. So here they looked at over 44,000 citations, and they filter up about 767 studies, and ultimately they chose 9 randomized controlled trials to include in this. And again, inclusion criteria was minimum 5 year follow-up, which kind of for our topic is great. And then they all randomized controlled trials. They looked at the endovenous therapy and they compared it to the conventional surgery, which is high ligation and stripping. And they excluded any study or case report that has been less than 5 years. And this is just the summary. 9 randomized controlled trials were selected. From them, they had over 2,000 legs were treated. And you can see surgery and laser had the highest treatment sample, and RFA and USG has fairly good number, and majority of those patients on those 9 studies were C2 to C4. There were no advanced C5 or ulcer patients. And then unfortunately, 5 year follow-up available data was around 62%, and the rest remaining 40% kind of lost follow-up in 5 years. And this is the list of all the authors and all the 9 studies. And you can see they all were randomized controlled trials. And from them, 7 of them actually compared laser to surgery. and one compared RFA to surgery and the laser. And then the two studies were done to compare ultrasound guided foam to traditional methods. And so this is the results, which briefly I'll talk about. And again, this slides can be a little bit busy, but I just need to quickly look at, if you can see in figure two, and again, the outcome they really look at was the recurrence, reintervention, recanalization, and neovascularization. So if you can see in figure two, this is the long-term recurrence rate of endovenous laser versus surgery in the figure two. And if you can see, the graph is kind of aligned in the midline, which really is the odds ratio. And to really, when it compared to laser to the surgery, overall, there were no statistically significant when it comes to recurrence. So the recurrence rate on both interventions were the same. And in the figure three, they looked at the long-term reintervention rate of the laser versus surgery. And here, what they found initially, one of the studies, you can see RAS 2015, has a little bit favoring surgery, but overall, the pulled diamond, which you can see here, pulled odds ratio, was kind of crossing the line, which is not significant. So when it comes to recurrence or reintervention, laser was similar to surgery. And this, the data now, the third outcome they really want to look at is recanalization or reflux in 5 years, laser versus surgery. And you can see, and again, there's many studies favoring the surgery. And this was, when it comes to the pooled data of all those 7 studies, the pooled effect, the odds ratio was statistically significant favoring surgery. So that means recanalization was high on the laser group. And uh, differently for nevascularization, they looked at overall, if you can see the similar 5 studies, everything's favoring laser because it's all about once we remove strip the vein, I think it has to do with the vascular endothelial factors regrowth. And usually we don't see much of the new vascularization with the endovenous therapy, but it's more common with the traditional surgery, which kind of shows in 5-year data on this study as well. And again, the laser was I showed, and this one is they compare radio frequency in the same study to the ligation. And again, they want to look at the recurrence, recanalization, nevascularization, reintervention. And if you can see, it was only one study was included that compare RFA to all the other treatments. And among all of them, you can see everything's kind of in the midline. So there's no really significant, statistically significant difference between RFA and high ligation. They had a kind of similar data. And ultrasound guidance foam scleral to the surgery versus to the laser. This was actually a lot of significant data was found, which I'll summarize in the next slide. You can see in here, when it comes to recurrence, recanalization, reintervention, all the both studies that they did favored surgery and then the laser. So the only thing was which we've seen when it compares to nevascularization, you see less revascularization and ultrasound foam group versus the surgery. This just to summarize that uh, ultrasound guidance for muscular therapy in the long term and 5-year data uh, did not had much of the long-term outcomes. And again, surgery was better. And then recanalization, and again, there's more GSV recanalization was seen in the ultrasound guidance foam group. And the only thing they saw was less was the nevascularization. Again, as we talked about intravenous treatments, we don't really see much of nevascularization. This is just a summary of that whole paper, and there's no significant difference between the laser to surgery. But then, what one takeaway point is higher for ultrasound guided foam compared to laser or RFA. So, and they looked at the other thing is higher surgery was the nevascularization, which I talked about. This just to summarize the things that we looked at the graph and overall. And the one thing I think they couldn't really generalize the clinical outcome because the data was more heterogeneous. All those 9 studies had different quality of life and VCSS assessments, so they couldn't really had the pool data from when it comes to clinical outcome. And again, similarly, this is another study that I looked up that shows overall incidence of Rivas when it comes to intravenous treatment. But unlike the other treatment, and this one, they did not include ultrasound guided film. They just wanted to look at intravenous thermal, and they looked at if there's any anatomical site causes of recurrent disease. And this was a meta-analysis of the randomized controlled trial, and this was done in 2000. I believe 16 in Boston. And uh, the metas, this is meta-analysis of all randomized controlled trial from 2000 to 2014. The minimum follow was 2 years, and they excluded the foam. They just included patients with the laser radiofrequency and compared to the traditional surgery. And the outcome they looked at was what the ultrasound showing in the over 2 years, what kind of anatomical sites that persist after the treatment, and what are the causes of recanalization or disease progression, and what were the reinterventions rate. And this, some of the studies that we already saw in a previous publication, some of them are here, and you can see all of them are 2 year, 3 years, and 5 year studies, and the sample size decent, and the results what they saw. So from all the seven, three of them were RFA to the surgery comparison. Four of them were laser to surgery, and again they end up having over close to 700 on intravenous treatment. And I'll talk about one by one just what the results were. And if you can see on clinical recurrence, and all three, when they compare RFA laser to surgery, they were kind of 20%. But the only thing that really stood up was re-intervention, re-operation rates was higher on the laser. And when it comes to anatomical site of recurrence, you can see on intravenous versus surgery, thigh was kind of was the most common site that recurrence happened, and thigh and calf and the groin and the popliteal areas were not really much percentage. And interestingly, on one study they looked at as 2 years versus 5 years, the recurrence rate almost doubled when it comes to the laser. So it's just highlighted here. And the cause of recurrence, and again, as previous studies showed, recanalization is common in intravenous treatment if it's a laser or a radiofrequency, not much common when it comes to surgery. But the neovascularization, and again, we see more with the traditional surgery. And again, they also looked at if there's any accessory saphenous vein has contributing for recurrence, which was like almost 20%. And then perforators and cap perforators is also here. So overall, this is again just a summary that I talked about. And move and this is the key findings. And again, clinical recurrence, duplex recurrence, reoperation rate not significant, but recanalization was high with the intravenous ablations, and neovascularization was high with the surgery. And a lot of studies were done in laser. There's compared to RFA. There's so many meta-analysis, a lot of randomized controlled trials, but the ones that are really has a long term. There's a class trial in UK that compared laser to the ligation, and what they found was the 5 year outcome for intravenous laser was like 89% occlusion, and the foam had the lowest, which is 51. But then this is the paper which I talk about, which I already did. And then again, another study that looked at the laser versus laser plus the saphenous junction ligation. And again, similar findings. We don't see neovascularization on the laser alone. Mostly neovascularization happens with surgery. Recanalization were high with the laser alone. And just a summary of the laser findings. Short term is great, but then overall 5 years occlusion is around 90%. And again, keep in mind recanalization, we always see higher with the intravenous. And this is the another study that is interesting. I see a lot of my patient when they come to self-pay, and really treating with the thermal could be costly, but to wanted to look at see how do I have to do endothermal ablation first. This was study really wanted to look at to see how foam on its own, the long-term effect of the ultrasound guided foam on axial veins compared to endodermal. So this was done, and they wanted to look at all the meta-analysis for randomized controlled trial. And this was published, I believe, in 2015, 2016 in the Journal of Phlebology. So inclusion criteria was all randomized controlled trials comparing ultrasound-guided film to endodermal ablations, and they removed all the non-RCTs, and they end up selecting four RCTs, which listed in here. And from them, for our long-term topic, three of them really kind of 12 months and 15 months and 3 years. One has only 6 weeks follow-up. What they found in the result is endodermal, again, consistently achieves higher anatomical success. But when it comes to, even though anatomic success is high, people did improve as far as the quality of life and VCSS in 5 years. What ultrasound guided was also kind of acceptable. So what they conclude was, even though anatomically long-term intravenous ablations for axial for GSV is better, but and again, despite occlusion rate, foam could be achievable comparable symptomatic comparison. And lastly, I'm just going to talk about where we are with the cyanoacrylate and the 5-year data. This is one of the great studies, randomized controlled trial that compared venous seal to RFA. I think this was presented in vein symposium and conferences by Dr. Kathleen Gibson, and they have published before the 3 years, but they also recently published the 5-year data to really see. In the 3-year data, they looked at the cyanoacrylate was non-inferior to RFA, and the purpose of the 5-year to really to see if the outcome really held up long term, and they looked at the durability, safety, and clinical improvement and SEEP class changes in patient satisfaction. And again, this is a randomized controlled trial, followed up to 60 months. The primary endpoint was vein closure and freedom from recanalization. Secondary endpoint was VCSS, SEEP class, and quality of life and patient satisfaction and safety. And again, you can see from 1 year to 5-year data, and overall, in summary, the closure rates are generally very high in mid-90s for at least 1 to 3 years, but remain good at 5 years. And again, this was non-inferior to RFA when it compared in comparison, and so it was has a good anatomical closure. And then besides anatomical closure, there's no new recanalization between 3 to 5 years. SEEP classification improvement, up to 40% improvement above two classes, and also VCSS and quality of life had both improvement in both groups. 100% satisfied, they reported in 5 years. And again, in conclusion, cyanoacrylate is durable when it comes to 5-year data, is non-inferior to RFA. That's what they concluded in the study. And there's some other studies which I didn't get the chance to look much, but this is just listed here. And again, this published a couple years ago to really compare. This was done in Turkey to really look at the long-term outcomes of laser, cyanoacrylate, RFA side by side. And the endpoint, they really want to look at the occlusion success and durability. And secondly, they wanted to see what procedures take a longer time, postoperative pain, complication rate, and time to return normal activity. And again, 232 patients from 2014 to 2017, recent study, and they followed that with 1 week, 6 months, 12 months, and annually for over 5 years. And interestingly, procedure time, I couldn't see the details how the cyanoacrylate was 13 minutes was the shortest one, but RFA was 27.9 minutes, and the laser was almost 30 minutes. And pain score highest was on the laser group, and then complication recovery. And the laser had more complications and longer recovery. And the ones that I really wanted to look at was the long term. So when it comes to RFA for in 3 to 5 years, RFA shows significant better long-term occlusions than the laser. And when it compared the cyanoacrylate to RFA, in 3 to 5 years, there were no significant difference, so they were kind of similar. And again, that's one of the last tables from the study. You can see in the top, the occlusion rate was kind of lower in 3 to 5 years compared to cyanoacrylate and RFA, and then VCSS, kind of similar improvement from the baseline before the treatment. And so in short, they're all the same, less than 2-year outcome, but when it comes to long term, RFA was better from the laser, and same to cyanoacrylate. And some other studies that are listed for fellows they want to look at. Some of them I already talked about. Uh, so overall, in summary, long-term data, 5-year data for RFA is good. 90 to 95% occlusion rate and reflux absence rate. The better quality of life measurements compared to traditional surgery. And then again, less revascularization. Similarly, with the laser occlusion rate, 5 years is high 90s. And again, better quality of life. And again, we don't see new vascularization. More, and again, from all the meta-analysis of all the randomized control trials, we see recanalization still higher around mid-20s when it comes to intravenous ablations. And ultrasound guided foam scleral showed high risk for recurrence. It was somehow 50% for GSV recanalization compared to surgery. And again, but overall, the quality, the clinic improvements were kind of something to pay attention that can still a patient have some sort of outcome. And for venous seal for cyanoacrylate, it's similar to RFA. There's a good 5-year occlusion date, and then not, and it was not inferior to RFA. And a couple of takeaway points I wanted to talk about just to understand recurrent varicose veins does happen. It has multiple interacting causes. It's a residual disease. If it's a new disease, it can happen because of recurrent reflux and new vascularization, not much nowadays. And again, understanding the source of the reflux is the pelvic of this, the perforated veins is critical, especially AGSV, we need to pay attention even though the modern techniques are reducing revascularization, but technical errors can happen. And again, disease progression is unavoidable in the long term. And things that I usually try to talk to our patients to see that management of CVI is challenging. It's frequently associated with the patient when they come in with a recurrent disease, they may have reduced patient satisfaction. We just have to need to set appropriate expectations. It's not a one and done thing. We don't cure the disease, we manage it. And patients should be told from the beginning of the treatment that the venous disease may not be confined for the single procedure. We really follow up is essential, is important. Thank you.